Hello, today I am being joined by Dr. James Hopkisson, who is Medical Director at TFP Fertility UK. Welcome.
Good morning. Thank you for having me on.
Well, today we're going to be discussing PCOS as it is PCOS Awareness Month during September. Please, could you start by introducing yourself, tell us a bit about your role, and then explaining what PCOS is?
I'm James Hopkisson. I'm a consultant gynaecologist based in Nottingham, and I'm the medical lead for TFP UK. I've been working in the field of fertility for about 30 years now. Polycystic ovarian syndrome is a condition that affects potentially 1 in 10 women and is related to a number of symptoms which can range from irregular menstrual cycles leading to problems with subfertility, weight gain. Some people will have problems with their skin, with acne, and some may have problems with hair growth, we call hirsutism, and male pattern baldness. So there are a number of symptoms that go up to make polycystic ovarian syndrome. It does come with problems later on in life, such as type 2 diabetes and being more at risk from cancers of the lining of the womb. So it's a condition that will last through your reproductive life and something that we can help with at many stages as gynecologists.
What's the difference when people refer to it as PCOS or PCO or PCOS?
Like many conditions, we give things names, initials. I think one has to look at PCOS as a spectrum. There are many different shapes, sizes, and people experiencing different symptoms. You can have polycystic ovaries or polycystic looking ovaries, PCOM morphology, without having symptoms of PCOS. And I think we have to bear in mind the issues with PCO, changes in insulin resistance, leading to secretion of excess androgens, testosterone, causing symptoms. We have to look at that as a whole throughout reproductive life and how we can manage the symptoms depending on where you are with wanting to have a family or managing your periods, managing your weight. There are different strategies at different stages of your life.
Thank you for that. Absolutely. Can someone get pregnant with PCOS?
Yes, they can, but they may need help. One of the problems with PCOS is having an irregular cycle, which often means not ovulating. What we see in the ovary of women with PCO is small follicles that have not gone on and developed to ovulate. So it's a bit of a misnomer. These aren't cysts. They're small unruptured follicles of around 8 millimeters. And one of the things I get asked about is, can I have these cysts cut out, removed? And I'm saying, no, this is normal. You've got a very good ovarian reserve, lots of follicles there. And, you know, when it comes to the treatments for helping people to get pregnant, they can range from modifying lifestyle, bringing your weight down, drugs to boost ovulation. They may be in tablet form or injections. Or if those don't work, moving on to higher level treatments like assisted conception and IVF.
And for people who are wanting a diagnosis, not sure if they have it, you mentioned that it's something that is often hereditary. So if your mother has had a history of it, is it something that you would commonly suggest people go and investigate?
I think if anybody is worried about their health, they should seek good advice. And there are a number of tests that we can do to look at the causes of certain of the symptoms. One always starts with taking a detailed history. When did your period start? How regular are your periods? what's been happening with your weight over puberty and on, and putting together a picture. And then there are a number of investigations that one can do. An ultrasound to look at the ovaries. That can be an internal ultrasound or an abdominal ultrasound. So there shouldn't be a fear of going in to see your gynecologist or doctor, your general practitioner, to organize a scan. And there are a number of blood tests that can be done to look at some hormones that may indicate whether you have excess androgen, excess testosterone. And we can do a small calculation with some of those hormone measurements to give you a calculation of something called the free androgen index. And there is a number above which would suggest excess androgen, which is linked to polycystic ovarian syndrome. So don't be afraid to go and ask for investigations and help with managing your symptoms, whether that's for fertility or just to regulate your cycles or deal with skin problems, hair growth problems.
Is PCOS easier to diagnose than conditions such as endometriosis?
Yes, I think it is. With the range of tests, endometriosis, one needs to do a laparoscopy to get a definitive diagnosis. One can treat based on symptoms of pelvic pain, cyclicity. And endometriosis is a very different disease with different implications for both quality of life and for fertility. PCO is something that you are born with. Its expression, the genes that you are born with, can be expressed in different ways depending on your weight, on your general health, and it's something that we can help you manage. If people are having chaotic periods, that may necessitate going on to some hormone or form of contraception. If somebody has excess androgen, there are cosmetic ways of dealing with that. And there are medications such as finasteride, spironolactone that suppress androgens. Obviously, one can't take those when trying to conceive. If you're trying to conceive, as I said, there are ways of helping to boost ovulation, but those have to be done in a fertility setting.
Does everybody who has PCOS show symptoms, or can it be silent?
It can be silent, and it's an interesting thought that does somebody with polycystic looking ovaries on ultrasound who has a regular cycle, if there was a change in their metabolic circumstances, weight gain after using the pill, weight gain after pregnancy, will their cycles change, and will the symptoms of polycystic ovarian syndrome become manifest? I think that is true, and that there are shifts through your reproductive life.
What about diet and nutrition? How much of a role does that play in helping with PCOS?
I think a huge amount. There are some studies that show that 60% of women with PCO at some time in their life are on a diet, and about a third have been reported to have altered or disordered eating habits, and which lead to things like anxiety, depression. The whole PCO morphology, symptomatology is linked into insulin and insulin resistance. And the more insulin resistant you are, the more fatty deposition there is, and derangement of androgen production, which leads to the irregular cycle. So having a healthy, balanced diet is key. I'm often asked, is it best to have a low carbohydrate diet, a low calorie diet? And I think it has to fit into your life. Any weight loss has to be controlled, sustainable, and dietitians are very good at helping you find the right way for you. And that may be adding in low GI carbohydrates, fruit and veg, omega-3, Adding in exercise and minimizing stress is also very important, because long-term health in PCOS is incredibly important, because there are higher rates of type 2 diabetes. It's estimated that about 50% of women with PCOS will go on to develop type 2 diabetes.
Right.
And also there's, unfortunately, because of excess androgens being converted to weak estrogens, there is an increased risk of cancers of the lining of the womb. And these are things that we can help control by healthy lifestyle.
Really good to know. Thank you. Is it possible to be misdiagnosed with PCOS, and why?
That's a really difficult question. I think with most women's health conditions, it is usually a delay to diagnosis. I think people can be given a diagnosis of PCOS if doctors are not looking at the hormone profile correctly. But I suppose absence of periods isn't necessarily PCOS. There are other causes of absence of periods aside from PCO, and that's where there can be some muddling. Ultimately, what we need to know is, what is the ovary like? Has the ovary got a high reserve, which is what happens in PCOS, and derangement of the hormone cycle leading to ovulation, which makes you have a regular cycle? Or is there a low reserve, going into the extremes of premature menopause, and the time up to the menopause, what we call the climacteric, where you're running out of eggs and having irregular cycles for that reason. So it's some simple hormonal tests should be able to direct you to the appropriate diagnosis.
Is PCOS connected to having a long luteal phase?
Again, an interesting question. The luteal phase is following ovulation. So the vast majority of women with PCOS with irregular cycles are not ovulating. So I would say it's more likely to be an absent luteal phase, that you're not getting that progesterone rise to get the lining of the womb to change from thickening in the first stage to secretory luteal phase when implantation can occur. So there is a derangement of the cycle, and that's what the fertility drugs will correct by boosting ovulation, and potentially with the addition of a mid-cycle trigger, ovulation, and then a normal luteal phase. So I'd say it's not a defect, it's not a long luteal phase, it's a derangement of the whole cycle.
Is there a connection between the antral follicle count and PCOS?
Women with PCOS will have a higher antral follicle count that we can see on scan. They will also have higher levels of the marker AMH, anti-Müllerian hormone. So when we see somebody in the fertility clinic with PCOS, those numbers will be higher, and they will guide us as doctors how to treat, especially in an IVF program, because those people with high levels of AMH and high antral follicle counts will have a higher chance of over-responding to fertility drugs and having a complication called ovarian hyperstimulation syndrome. So there are strategies that we can use to minimize that, such as the use of metformin. Some people will be on the supplement inofolic. There are different regimes in an IVF program to minimize response and keep people safe and minimize the discomfort and harm that OHSS can bring.
You mentioned AMH and that higher count. Does that mean that people with PCOS can do better with IVF because they're likely to have more eggs?
IVF predominantly is a treatment that requires a good number of eggs. We have to balance our desire to get eggs with the risks of hyperstimulation syndrome. We know that the more eggs we get, the more eggs that will fertilize, the more embryos that we will create, and therefore the likelihood of finding the right embryo that we can replace and be successful. So there are some concerns that egg quality in PCO may be slightly lower, but often that is counteracted by the number of eggs that we get. But I think we have to look at individuals, grouping people and saying patients with PCOS have a lower success rate is not really accurate. I think because the spectrum of symptoms, morphology of people with PCO varies from people who are very slim, no periods, to people who are overweight with chaotic bleeds. You know, we're putting together all of these people into one label, and certainly we'll have different outcomes with different people depending on their own characteristics, and that's why it's so important to individualize care, be that dietary advice, fertility advice, advice outside of fertility, finding a treatment that helps with the symptom that is causing your patient to have distress, worry, anxiety. And some of that may be psychological help as well. You know, we know that people with PCO will have higher levels of anxiety and depression because of their symptoms. So, you know, it's a holistic approach, and we mustn't just concentrate on fertility when there are so many other things going on in the person's life.
Absolutely. At TFP Fertility UK, do you often see patients coming in who have a diagnosis of PCOS or are about to be diagnosed with PCOS?
At TFP, we will see all patients from the beginning of their fertility journey to those who are coming in for a second opinion, having had cycles of IVF elsewhere. So our clinicians are experts in the field of fertility, are able to make the diagnosis, give the right advice on healthcare, your general health, diet, exercise, fertility treatment, and ongoing care outside a fertility program. And I'm acutely aware of how difficult it is at the moment to get good advice. So I'd encourage people to get in contact with their local TFP clinic, even if it is just to dip your toe in the water. You're thinking about fertility, you want some advice on, you know, how do I optimize my chances? A fertility assessment gives you information to make informed decisions about going forward. You may not go down the route of fertility treatment that month, that year, but you get information about you and you can plan. And I think that's very, very important. Family planning isn't just about contraception, it's about when to start trying and optimizing your chances to conceive when you want to.
Absolutely great advice. When people come to see you, is there a standard approach to treatment? Do people go straight into IVF if they're trying to conceive, or are there other things that can be tried first?
There is never a standard approach in fertility. I think all care should be individualized, and we have a range of treatments, be that starting with improving lifestyle, looking at ovulation induction, which may be with drugs such as letrozole, clomiphene, that are anti-estrogens that boost ovulation. There are drugs that we can use to inject, injectable FSH to stimulate the growth of follicles. And then one can move on to IVF if it is appropriate. We look at both partners. Obviously, if there is a male factor, yes, you may embark on IVF sooner. If there's a tubal problem, onto IVF sooner. But it's individualizing care to provide a bespoke range of treatments for people. And I think that's the most important thing, is to sit down with somebody who will look at the whole picture to give you advice, not just about your fertility, but about lifestyle, to minimize the risks in the future to your general health.
Thank you. That's great advice. Follow our link in bio to reach out to the team at TFP Fertility UK, who would be more than happy to help with any advice around PCOS or anything else related to women's health and fertility. They have lots of locations around the UK, so please do seek their advice and make that first step. I also wanted to ask you, Dr. Hopkisson, one of the things we always seem to see connected for some reason is endometriosis and PCOS. And I know we briefly touched on it earlier, but is one of those, inverted commas, worse for fertility than the other?
I don't think one can say it is worth. Endometriosis has a wide range of symptomatology, but also presentation. And we grade endometriosis from stage 1 to stage 4, depending on the site, the amount of endometriosis, and it brings its own challenges. I suppose there isn't a competition out there for which is the worst fertility diagnosis to have. All of the conditions that impact on fertility, we look at and try and structure an individualized plan to overcome. So if somebody has tubal damage with endometriosis, they go to IVF. If they have a low reserve because of ovarian disease in endometriosis, we can change the stimulation regimes to optimize egg yield. In PCO, we may struggle to get people to ovulate. So people may have to jump from ovulation induction into IVF, and the IVF program will have risk because of their high ovarian reserve in terms of minimizing response to minimize risks of OHSS. Some people will have immature eggs, some people will have poorer egg quality. So it's finding strategies for the individual, and we learn as we go through treatment with both PCO, with endometriosis, as to how to optimize care for each individual couple as they come through.
I think that's a brilliant point to finish on, the fact that as a team collectively, TFP Fertility UK do focus on a personalized approach. So I really do suggest that if anyone wants to have a personalized treatment plan and investigations and some answers, then please do reach out to the team via the link in our bio. Thank you so much for your time today. It's always such a pleasure chatting to you and to bring light to a topic that is obviously a huge condition affecting many, many women around the world. And for September, it's great to be having this conversation and longer term.
Well, thank you very much for having me. If people do have queries or questions, somebody at TFP is always there to help.
Thank you.